Morning, morning everyone. I hope you're all good. Everything is looking like it's working from my side, so hopefully you can hear me and see me okay. If you want to pop any messages in the chat, I'm just going to pop one in, just make sure everything's working okay. That's looking good. Okay, so last week we started on looking at the spinal discs, and then this week we're going to take that a little bit further. So we're going to have a look at some of the pathology around discs. So we talked about a little bit about introducing herniations, and we're going to discuss the topic of sciatica as well, and then that will lead us nicely then into the anatomy of the spinal cord and all the nerve roots and all that kind of stuff. So we're going to go down into that area after this. I think usually we do the muscles next, but I think it ties in quite nicely, so we'll do that one next. So this is a bit of a recap. And we did cover this a fair bit last time. Just get rid of that. There we go. So we did cover this last time, but I just wanted to briefly recap some of these things. So wanted to go over a little bit about what discs look like. And most people who've studied a bit of anatomy realise that there is a couple of components to a disc. So we've got the annulus fibrosus, which is the outer ring, and then the nucleus pulposus in the middle. And so the again, apologies if you're having your breakfast, if you're in the UK listening. If you're elsewhere in the world, then it's not so bad. This nucleus has the consistency of phlegm. Lovely. So if you just imagine that. So that's what this is like in the middle. And the analogy that is often used incorrectly is the analogy of a jammed donut, where things just kind of like splurge out of the disc. So we're going to have a look at that in a bit more detail, see exactly what does happen. Last week we talked about these end plates. So this is a cross-sectional view looking at it side on, and this is a vertebra here and that is a vertebra there, so it's kind of been chopped through the center. And this end plate is not a plate, as we said before. It's more like a filtration system so that the disc can get its nutrition. And that's really useful in a second when we start looking at the herniation of a disc and the how a disc ages over time. Okay, so that's quite important, that bit. Well, here it is. So we've got the cartilaginous end plate, which, like I said, is not like a plate. It is. It has a blood supply. It is the filtration system for the disc, so it can get its nutrients. And the way that the disc gets its nutrition is through movement. So when you compress, if you imagine like you get a sponge, you squeeze it and you put it into a bucket and then you let go, and then the sponge slowly fills with water. That's basically what happens to your discs. So if you squish it down, and then as it comes back up again, it will draw the nutrients into the disc to keep it nice and healthy. So if you don't have movement in a particular joint space, then that disc will start to decrease in size. And we see that in the literature when we're looking at some of the normal changes as a disc and the vertebrae start to age. So its function to prevent the well-hydrated nucleus from bulging into the adjacent vertebra as well. That's what this end plate does. However, because of the axial load, so the load coming up from the bottom and from the top onto a disc, one of the places that a disc will usually herniate is inferiorly or superiorly, so up or down, and that because the vertebral bodies are on top of them, it will then push up into the end plates and it will create these little they're called Schmall's nodes, these little indentations into the end plate. So as we get older, and the tissue starts to degenerate. Lovely word, but that's basically it is what happens. We get a calcification of the end plate, so then the nutrients into the disc are harder to get there. So the disc will start to dehydrate basically as we get older, and like I said, we see that in the literature. This is what the annulus looks like when it's cut through. So we've got lots of these circumferential rings. There are between 10 and 20, depending on the vertebra that we're looking at. And they're all in different directions so that the disc has integrity in every direction. And I said this last week, imagine if they were all in like a ring around the nucleus, and then you twisted, it would just rip the disc apart because it would have no integrity in all different other directions. So because we have a layer going in one way, a layer going another way, a layer going another way, we've then got really good integrity. However, the nucleus can still leak out of the disc, and we'll talk about that when we start to look at herniations and sciatica and all the different symptoms that are associated with that as well. So this is just another image of that annulus in all the different directions. And and it's the nucleus is a bit like porridge or phlegm. Lovely, right? What a lovely image to have in your mind. So this is axial load, and forgive me if I'm going through quite quickly. We did cover this last week, so if you wanted a bit more of a slowed down version, then tune into last week's episode where we went over this. So this is the axial load, so the load through the kind of top and bottom of the vertebra. And because of that axial load, we get a bit of a bowing effect on the disc, so either side, to distribute the load. So that, and again, this is a common misconception with discs, that they absorb shock. They don't absorb it; they help to distribute it. Yeah. So because if all of the shock was being absorbed by the disc, then we'd be in trouble. So they spread out amongst all the tissue that are around it. These are the Schmall's nodes that I was just talking about. So a disc is likely initially to herniate either upwards or downwards rather than forward or back, just because of the axial load. So it herniates upwards or downwards into the vertebral body. So obviously the end plate is here, and what you will find is if the nucleus does herniate posteriorly and then contact anywhere within the vertebral canal, so where the spinal cord goes, you will find within that nuclear material usually bits of bone, so bits of an end plate, but cartilaginous structures, bits of annulus. So that it's a kind of mishmash of all the things that it's been in contact with if it does eventually herniate. So and again, useful to know when we get onto the next bit, when we start looking at herniations and why we think things cause symptoms. So yeah, it's not really a shock absorber. It's more like a distributor, a shock distributor or force distributor. That's a better description. And then this was something that may be new to some of you. We did talk about this last week again, but this is why the jam donut analogy doesn't really work, because when you obviously have a hole in a jam donut, and when you squeeze the front, all the jam comes out the back, and that's what we imagine when we bend forward, and that's why things hurt posteriorly, like someone bent over or they sneezed as they were bending, and their back goes, and then they imagine this jam donut effect. The only problem is the disc doesn't usually bulge that way. Okay, so flexion causes usually an anterior bulge. So when you bend forward, it bulges forward. It doesn't shoot the jam out the back. Okay, so which is quite interesting because it's just different to what we have in our mind and what we've always been told. So they, and again, when I trained, we were taught that if someone bends forward and they have pain, then it's likely to be the disc. And if they bend backwards and they have pain, it's likely to be the facet joints. And again, this is just way too simplistic a thought process, too simplistic of a biomechanical model around why things hurt in your back. There's lots of other stuff going on that need to be considered. And when we start to break down those things, well, this just is a classic. And also when our normal stance, and we covered this a few weeks ago, is when we are stood upright, we have a lordosis in our spine, so it bends forwards. So when we bend forward, when we flex, the spine actually just basically straightens out. So it doesn't bend the other way to put pressure on the front of the disc to splurge it out the back. It basically straightens up. Yeah, so it's, again, something else to make you think about, well, actually, that's not what I had in my head when we think about disc herniations. So even though this information is out there, and this is the usual way that a disc will move, it's not always the case. Okay, so it depends on a lot of things. So it depends on if there's any pathology. It depends on the specific morphology. So the characteristics of that person's spine, it may move in a completely different way. And this is why it's impossible to say bend forward disc, bend backwards facet. It's just, there are so many factors involved that that is just way too simplistic. There we go. Excuse me. So it's too simplistic an idea, and it's an incorrect way of thinking about it according to the usual biomechanics when you load a disc, which was the image that we've just seen. So we did touch on this a little bit, and but I want to leave that there and then have a look very briefly at this. Sorry. Okay. If you've not seen this before, there's a lot of information on here. So what I want you to concentrate on are these bits just here. So this is what comes out of the side of your vertebra. Yeah, so the nerve root, it has two main pathways. You have a motor pathway, which is the information coming from the brain down the spinal cord, out and then towards the body. So it could be muscles, it could be a gland, it could be an organ, depending on what it innervates. And if you've not heard that term before, innervation just basically means switches on. So it switches on a muscle or it switches on a gland or whatever it is. Okay. And then we also have a sensory part of the nerve root, which is the information coming in from our body. So our body is surrounded by sensors. We've got sensors in our skin, in our joints, in our blood vessels. Obviously, the things to do with senses, so hearing and eyes and taste and all that kind of stuff. So all that information is being received by the nervous system all of the time. And then that information is coming into this area just here. Okay, so this bit here, this is a bit of a bulge in the disc, in the nerve root. Sorry. So what you've got is any kind of collection of cells is or kind of like a thickening of an area is often called a ganglion. Okay, so we've got that word up here. There we go. So this is the posterior or dorsal, and we'll talk about that when we get to the spinal cord a little bit in a next episode. The dorsal root ganglion. So this is the nerve root. This is the posterior part of that nerve root, and this is the bit that receives sensory information. So it's called the DRG, or the dorsal root ganglion. So you might hear that term quite a lot. It's thicker, so it looks bulbous because there's a big collection of sensory neurons in that space. Okay, so there's a lot of information going into that particular part. And then this is a cross section of your spinal cord. So that information will come into here, and then that will go up to your brain and let your brain know what's going on with your body. Okay, so that's useful for this next bit, which is this bit. Okay, just going to go back a bit. Right, so we're going to have a bit of a chat about sciatica. And we needed to know about the disc. We needed to know about the structure of a disc. We needed to know about the nerve root and the structure of the nerve root before we even start to look at something like sciatica. So sciatica is a really complex subject, and it's not a very useful term, sciatica, because it just basically means pain down the back of the leg. So that's not very useful, because if you Google sciatica, and if you're a patient and you've got lots of pain going down the back of your leg, then immediately you will Google it, and it will come up with some horrific things that you've probably got cancer or something like that. Now, the likelihood of it being some major pathology is very, very low. But if you're watching this and you're a therapist, then obviously we need to know those signs and symptoms, and we will talk about that when we get into the spinal cord, and especially around the lumbar spine. But there's also lots of other stuff going on which we need to know. So if you're watching this as a patient and thinking, oh, I need a better understanding of my body, then this should hopefully help you work out some of the symptoms that you're currently feeling. I have first-hand experience of this. It is horrible, and there's different symptoms depending on what the problem is. And I've had 2 out of the 3, and was it 2 out of 3 ain't bad, right? So we've got these 3 things. And it's important to understand the differences between the 3, because they always get confused with each other. And then the term sciatica is used, which doesn't really help, because any one of these could be sciatica, because sciatica is not a diagnostic term. It, like I say, it just means pain down the back of the leg. So is the pain down the back of the leg radicular? Is it a radiculopathy, or is it referred? And that's when you do an examination on someone and you listen to their case history, these are the decisions that we need to make and work out exactly what's going on with this individual. So first of all, we're going to have a look at referred pain. And by the way, I like the new colour scheme. I'm moving away from the kind of black and red. I've got, I don't know, it's a Farrow and Ball colour. But then I've noticed as well that the Therapy Expo is just rebranded and using pretty much the same colour. So I must be onto something if they're doing it as well. So anyway, if you hopefully you like it. So referred pain. Now, a lot of this information I've gleaned from a really, really good book. He's done a couple of good books, but it's by a chap called Tom Jesson. So if you haven't heard of Tom before, definitely go and have a look at his stuff. He's written a book on cauda equina, and he's written a book about sciatica, and they're both brilliant, and got some really nice diagrams and stuff in. So some of his terminology I'll use within this session as well. So definitely go and check his stuff out. Now, referred pain, Tom refers to referred pain kind of like a cloud. So it's not specific, it's not shooting, it's a bit like, it's dull, achy, diffuse. Okay, so it's that those kind of symptoms. So when you're listening to someone's case history, or if you have these symptoms yourself, if they're dull, achy, and diffuse, then it could be referred pain. So what the heck does that mean? So there are two main types of referred pain. They can be visceral. So these are coming from the organs themselves. Yeah. So for example, the liver or the spleen, maybe something like. If there's an issue with the ovaries or the intestines, that can often refer into your back, so it give you back pain, or maybe hip pain. And you get kind of dull, dragging kind of sensation. So, but it can also be somatic, which is from the bones, the cartilage, the muscles, so the body, the soma. Not though the nerves, although the nerves are obviously involved because we're detecting a sensation, but the insult, the lesion, is not to do with the nerves. Yeah, it's because those give you a completely different kind of symptom. The nervous system is involved, but the issue is with either the body, so the bones, cartilage, and muscles, or the viscera, the organs. So why do we get referred pain? So referred pain, as it says in its name, is pain that is felt somewhere, but actually the problem is somewhere else. And if you have ever experienced a kind of dull achiness down your thigh and thinking, oh God, I've got something wrong with the disc, then the pain with this is quite broad. And then when you touch the area where you feel it, there's nothing there. There's nothing that's sore, and so your body is interpreting it as being in a specific area, but some of the information it's getting is not quite right. So the body in its wisdom is kind of making up where it could be coming from. So this is an example of that. It's called crosstalk, and the crosstalk is happening at the level where the information is being received by the nerve roots. Okay, so this is a classic one. This is coming from the viscera, and this is why whenever you see something online in a group where somebody is saying, oh, I've got a patient with shoulder pain, what could it be? Oh my God, it could be loads of different things. Yeah. And it's really, really difficult without questioning someone to get information or get a diagnosis online. Yeah, it's just impossible. Some things are quite obvious, but you would still want to check and you'd still want to question people. And one of the things is because of things like this. So we've got this nerve called the phrenic nerve, and the phrenic nerve is from C345. So the little rhyme is C345 keeps the diaphragm alive. And what C345 does is it innervates your diaphragm. So it's this switch for your breathing. It happens automatically. You don't need to think about it. Yeah, so it's automatic function, and it should just happily contract and relax or contract, because it just relaxes on its own, the diaphragm day to day. Okay. The problem is though, and this is something called Kerr's signs. You can look this up if you want to. If you have a problem with your liver, then and there's some kind of irritation or enlargement of the liver, that then in turn can irritate the diaphragm. So what happens then is that irritation, because the sensory receptors in the viscera are usually quite poor, and it makes sense because you don't want to feel everything that's going on in your guts every single day. But when something is enlarged and it's pushing on other structures, that's when you start to detect things, because the sensors start to go off. Yeah. And the sensors on the diaphragm, when there's an irritation with the liver, they then refer they send that information up to C345, which is what it's supposed to do. And then the brain receives that information saying, right, there's something going on at C345. What could that be? The other areas that are supplying or are supplied by C345 is this area of your shoulder. So the sensation from here also goes into those nerve root levels. So we have this crosstalk saying information is actually coming from here, yeah, but because of the proximity of the shared nerve root, the brain thinks it's actually coming from here, and you get shoulder pain, usually on the left. Okay, so it's very common. It's called shoulder tip. Yeah, so you get this literally like kind of around the acromions AC joint sort of area, and that shoulder pain is always there. So these are where some of you might have heard of something called red flags. So a red flag is when something just doesn't sound right. Yeah. So if you've injured your shoulder, you've usually done something. You've usually lifted something or pushed something or fell on it or whatever. None of this would have happened. When you do a shoulder examination, you sometimes go, oh, I can't do flexion, I can't do extension or rotate or whatever it is. Yeah, so something in the biomechanical assessment of that shoulder is impeded and it reproduces the symptoms. There won't be any of that. When you touch it, it's sore. It won't be sore because the problem is not here. The problem is down here. So this is why we have to broaden our questions when somebody has pain, because it could be referral, and in this case it's a referral from the liver because of the issues with the diaphragm. So there may be some digestive issues that are going on. There may be some jaundice. You might notice the colour of their eyes are a little bit yellow, and if you don't have that thought process in your head, you won't ever think that there's a liver problem when they come in with a shoulder issue. And if you do manual therapy, you might treat the shoulder, treat up into the traps, and hopefully it will ease off, but nope. And this can quite easily go missing. So yeah, that is a visceral referral. Okay, so it's like I say, it's quite common. There are lots of different visceral referrals and the patterns are very common around the body. And a classic one is the heart. So a heart attack, you don't feel in the center of your chest. You might feel it in your mid-thoracics, so at the back, posteriorly, but usually the pain is felt up into the jaw and down the arm. Yeah, but your heart isn't located in the arm or in the jaw. So we get this referred pain because of the crosstalk from the irritation that has happened within the pericardium and the myocardium. Okay, and as Tris says on there, another referral pattern into the shoulder is from lung cancer. Yeah, so people can have cancerous tumours. They can have liver sclerosis issues, they can have spleen problems, and they can refer into the shoulder. So again, it's not to scare you because these things are quite rare, but I've come across it. I had a patient who had lung cancer who had these symptoms, and I know Tristan has as well. So it's something that when we do our training, we do something called a review of the systems. So we have a look at all of the systems of the body. Even if you've got a problem with your big toe, we'll still ask you the initial questions about the whole of your body, because we want to know that information to see if anything could possibly be referring to that particular area. Okay, so that's what's going on. And it's really, really common as well to have that referred pain from the musculature as well. So then you've got this. We've got radicular pain. So radicular is to do with the nerve. Yeah, so Previous one, referred pain, was to do with the either a referral from the viscera or the muscles. And yeah, Carol's had 2 clients with referred pain like that as well. Can you recommend somewhere to look up these symptoms just for my research? Yeah, if you just put in visceral referred pain, it will come up. The book to get is a book called Differential Diagnosis for the Physical Therapist, which is by Goodman and Snyder, which is Snyder. That book was my Bible as I was training, and is how I've created a lot of my course content from that book. So yeah, you can have a look at those resources. Radicular pain, this is actually from the nerve this time. Excuse me, sorry. So, well, not going to go into this too much, what action potentials are, but they are basically the how a nerve works when it innervates a structure. So when you turn on a muscle, you get an action potential. It goes to the muscle. You get a release of calcium, and then it creates a muscular contraction. So that is supposed to pass up and down the nerve roots. So when you think about doing something, it goes down the spinal cord, out via the motor part of that nerve root. Remember, I showed you that picture earlier, down to the muscle, and then basically it will jump along all of the neurons that it's connected to, and then when it gets to the end, it will release whatever enzymes, or create a muscular contraction, or whatever it is. So it's supposed to pass through those nerve roots. Yeah. So where that dorsal root ganglion was, and where the motor part of the nerve joined together, that the action potentials are supposed to go through there, not be made by them. And this is the problem with radicular pain. So at the nerve root level, so where the picture we saw before, we have something called an ectopic impulse. An ectopic just means it's in the wrong place. So this impulse is being generated by that nerve root, and then shooting the symptoms down that nerve. So usually it's from the nerve root or the dorsal root ganglion, which is what we've just seen before, and it's usually sharp and shooting, which is very different to dull, diffuse, and achy. Yeah. So this is that there's usually a clearly defined line of where the pain is going from, and it's usually from a specific nerve root. So the root has although there is a lot of crossover. Okay, this is again one of the problems with this. So a nerve root will be affected. That ectopic impulse will then shoot down that nerve, and it will follow a usual pattern, although it's not the same every single time for every single person. When I had radicular pain, it was because, well, I don't know what it was because of, I just had it, but the symptoms I had would literally just shoot into my heel, and it will be like a whoomph down into the heel. I guess I'm quite lucky that I've actually experienced it. I'm looking on the bright side and thinking that it was horrible, but it was so different to anything else that I'd felt. But it went straight into my heel, and this is one of the differences usually with radicular symptoms and coming from a nerve root, and referred pain coming from a muscle or a joint or the viscera. So referred symptoms, if they're in the lower half of the body, they don't usually go below the knee. Okay. Radicular symptoms go below the knee. Okay. So that's one of the big differentiators between the two, whether it's radicular or referred. But we do have issues with this as well. So let's and then we got our last kind of category of sciatica is a radiculopathy. Now this has got nothing to do with the symptoms, so you can have no symptoms and radiculopathy. You can have raging symptoms and radiculopathy. This is to do with a loss of nerve function. Now, this is when things get nasty, because if you lose nerve function for a specific period of time, then you will have a loss of function for possibly forever. And this is why something like cauda equina syndrome is really, really important to be able to highlight and put as part of your thought process when somebody is coming in with any kind of lower limb symptoms, lower back pain. Because if the cauda equina is disrupted and the nerve impulses are disrupted for a prolonged period of time, the nerve will then start to die and they may never get that function back. And the functions that are usually lost are sexual functions and bowel and bladder functions, as well as lower limb motor issues. So it's really, really important that if you don't know how to test nerve function, then you refer them to someone who does, or you refer them to A&E. Okay, depending on the symptoms. And we'll talk about that when we get to the spinal cord. But a radiculopathy is not a pain presentation. We're not talking about like a radicular symptom. Radiculopathy is to do with the nerve function. So we've got an injury at the nerve root, and there may be dull or absent reflexes. So when you do your reflex testing, like this patella hammer here, the nerve doesn't, or the reflex doesn't really happen. And I do a session all about reflexes, but just very quickly, when you tap a tendon that is already extended, information from that tendon and the spindles within the muscles will tell your spinal cord that muscle is being stretched really quickly. And then what it will then do is send an impulse to the muscle to contract to stop it from stretching. Yeah, so that's what we're testing. So we've got the sensation from the tap, which is the stretch on the spindles, that information going into the spinal cord and then immediately coming back to the muscle to tell it to contract. So if we have a problem with the reflex, then there's either a problem with the detection of the tap, so it can't pick up the stretch, yeah, so the sensation is affected, or it can't contract the muscle because the motor part has been affected, or potentially both. Yeah, we wouldn't know. We just know that there's a problem with that circuit and the circuit's not working properly. Okay, so that's what we would definitely do a reflex test. We would also do dermatomal tests, which is loss of touch sensation. So you might feel, might not be able to feel sharp objects, might not be able to feel soft touch, might not be able to differentiate between something that's hot and something that's cold. So the sensation just isn't quite right. Yeah, and also a loss of muscle strength. So when you test the muscles, they feel weak. Yeah, so I say they feel weak, they test weak. You can't feel a muscle and go, well, that feels weak. You need to test it. So when you test the muscle, it's weaker, and you obviously compare it to the other side. So there may be some symptoms with this, but it's not necessary for them to be there. Okay, so everything to do with the radiculopathy is to do with the nerve function. And that's the differentiator between referred pain, radicular pain, and then radiculopathy. Those are the three main categories. The only problem is we haven't got a blooming clue what it is. And it's probably a combination of all three. You're not going to have, well, very rarely, going to have one without the other, or one without the other two. Yeah, so you can have severe radicular pain, so sharp shooting pains, and no radiculopathy. That's exactly what I had. Yeah, so I had no loss of function. It just hurt like hell, and it was mainly getting out of a car. And as I stood up, I would just wait for a second, and then it would just go whoomph. And then once it had happened, then it went, and then I could carry on again. But it was really, really predictable. But I had no numbness, I had no weakness, anything like that. I could still do my normal activities. The symptoms can shift. So week to week, month to month, they can change around. And then if you throw into the mix as well some referred pain from the muscles as well. So if you've got radicular symptoms, that can often change the way you move. So you get an altered gait pattern, which then can overload certain tissues, certain structures, which then will cause a referred pain. So then you get this diffuse dull ache with a shooting pain. Just horrendous. Okay, so it can be a bit of a mixture. We can get danger messages from a disc herniation causing referred pain. So remember, it's not just the muscles and the joints, it can be the disc as well. And radicular pain from the nerve root compression, if there's some inflammation, which we'll have a look at in a sec, but next week. And then radiculopathy due to an insult to the nerve root. Yeah, so we can have all of that going on all at the same time. So it's very difficult to pin one thing down as the reason for the symptoms. But what we need to check is that one. Because if you lose nerve function for any prolonged period of time, you're in trouble. Okay, so that's the one thing that we definitely need to check immediately to exclude that as part of our differentials for going forward and what to do with this individual. And I think we'll leave that there. So Triss has asked, pain down, I'm guessing pain down the sensory or motor nerve. That would usually be part of the dermatome, so sensory, but it could be cutaneous nerve branch as well, that where you'll get the sensation. It's usually dermatomal. Okay. The irritation at the DRG cause radicular pain down the sensory nerve. Usually, yeah. And it, like I say, it could be a cutaneous field, or it may be a dermatomal kind of pathway, if you like. The dermatomal usually, because it's usually quite a specific area, although it can vary from person to person, but it's usually a line rather than a broad area, which a cutaneous field would be. But this is the problem. It could be a number of different things. It's really hard to say this is what's going on. So I think that we're about halfway through this, so we'll obviously pick this up next week. But I think one of the biggest things is make sure it's nothing nasty. And then whoever has these issues, we just support them going forward. Okay, because that's all we can do. And anybody that says they've got the cure for this kind of stuff, you need to avoid like the plague, because they wouldn't have a clue what's going on. It's a bit further forward. I was hoping it would be the next little bit, but there's a nice slide coming up about that. Cool. So we'll leave that there for this week. It's quite a big topic to cover, so we'll crack on with it next week as well. Let's pop that back. There we go. And if you've got any questions about what we've just covered, then pop them in our Facebook group. And if you're not sure of some of the terminology or where to find more information, then just give me a shout. But the differential diagnosis book by Goodman and Schneider is really good. I say Schneider, it might be Snyder. And then what else is there? And Tom Jesson's stuff. Yeah, so if you've not heard of Tom before, have a look for him. It's Jesson. So have a look for those two resources. They're both really good. Cool. I will see you next week, Monday, 10 o'clock. See you then.